we're kicking off with Fleur Riley, who's going to be talking about It's Like a Shining Light, Prioritising Patient Perspectives on England's first Heroin Assisted Treatment HAT programme. Are you okay, Fleur? Are you ready to go? So ready to go, and quick 10 minutes. Thank you.
Hi, really excited to be here. My name is Fleur. I'm going to talk to you about a project that we did looking at heroin assisted treatment in England, which was led by Professor Tammi, who is over there. It was part of a slightly larger project that was a three-part project evaluating the treatment, and we explored staff and stakeholder perspectives, service user perspectives, and we did a small pilot examination of health needs, but I'm just going to talk to you today about service user perspectives. A very brief background. In Britain, we have the highest reported opiate using population in England, and drug-related deaths are at the highest rate ever at the moment, with opioids implicated in over half of those deaths. And we do know that of the people who are opiate dependent, there's a population of them that try treatment over and over and over again, treatment refractory individuals who try methadone and the standard treatments, and it just doesn't work for them. So heroin assisted treatment is aimed at filling that gap in treatment for those people. Heroin assisted treatment, HAT, involves prescription medical grade heroin as a treatment for opioid dependency. It's got quite a really established evidence base. Started in Switzerland in the 90s, it's been rolled out in lots of other countries. And it was evidenced in this country with the randomised injectable opiate treatment trial, or RIOT, which is much easier to say. And overall, the evidence base, which is mostly quantitative data, shows really a range of really good impacts, and that reducing illicit heroin use, reducing criminal behaviour and drug-related deaths, improving service users' physical and mental well-being. There's not too much qualitative evidence out there. The service users' voices really are missing. So when it came to England, it was implemented in 2019 in Middlesbrough for the first time in a non-trial setting. It had capacity for up to 15 patients. The model that they adopted in Middlesbrough involved twice daily supervised injection of diamorphine, accompanied by methadone, complementary methadone. And we did a very small evaluation was done, and it showed the same kind of positive effects that were shown in the international evidence, but again, no qualitative evidence. So we interviewed all participants on the heroin-assisted treatment, 10 who were current patients, 1 who had completed treatment and 1 who had withdrawn. They varied from 2 weeks, just 2 weeks in treatment, to 2 years in treatment. We did semi-structured interviews face-to-face, and we did some thematic analysis. So the main themes I'm going to talk through was about how the participants overcame barriers to treatment engagement in the first place. So recruitment, barriers to staying in treatment, so how they overcame barriers to treatment retention, and then their experiences of healing and recovery that they talked about from the treatment. So impact. Okay, so in terms of getting involved in treatment in the first place, there was a general lack of awareness around the treatment. It wasn't really out there in the community, and I think that's to do with the target population being those treatment refractory individuals who aren't engaged in treatment. So it's actually, they just weren't aware. Those who were aware spread the word between each other, but they also had some concerns around eligibility criteria, because there was a prerequisite to be stable on methadone for about a month before you start HAT. And obviously for these people who had always struggled with the methadone treatment as standard, that was quite difficult for them. It took them a while to kind of get settled on that. So there's a bit of a barrier that is a prerequisite to treatment. The other concerns were kind of just a lack of confidence in treatment and a lack of trust in services in general, which again is to do with these treatment refractory individuals who've maybe had bad experiences of treatment, and certainly repeated attempts at treatment that have been deemed to fail. And particularly the funding is always rolling, and they knew that. like Frankie says, how long am I going to be funded for? What happens if funding goes and then I'm left back on the streets? I'm probably going to end up back in jail. My future is basically in the hands of HAT. So the participants were really aware of the issues around funding. And it made them, concerned to engage in something that had might have such a negative impact if it was taken away. And this was overcome really predominantly by their own motivation for a new kind of treatment. Like I say, so many of them had tried so many treatments in the past. Bobby describes himself as desperate to get on the course. And Ryan here talks about he's really aware of the fact that he might be close to death at any minute, especially due to the kind of like unpredictability of street heroin, its quality. This stuff wants me dead, it won't stop until I'm dead. So that really strong motivation overcame those initial barriers to recruitment. Okay, so actually while they're in treatment, the main barrier that they experienced was around the kind of twice daily visits to the clinic. So if you think they come in the morning, they come in the afternoon, 365 days a year, Christmas Day, everything. And it really does restrict what they can do in their lives, how much they can re-engage in society. John took 8 buses a day, so a lot of them kind of navigated that by, they would come for the morning dose and then mooch around in town and then do the afternoon dose. But again, it's like this kind of displacement of these people that are already quite displaced. They actually found it quite hard to find that level of kind of being settled within their own lives. Also, HAT was embedded within an existing clinic. And that meant that they would sometimes be in contact with other non-HAT patients that they know. They might come into contact, other people that were there getting drug treatment, like methadone, see them outside, see them in the car park, see them in the waiting room. They might owe them money, they might be friends, and this really increased the risk of re-engaging in that illicit market. And also, like Bobby says, I saw people I know and I went with them, and then he would use again. And he talked about 3 times he kind of went to a place, did a bit of something, did a bit of something else, and then, and depending obviously on his, or on all the participants really kind of like went through, ups and downs, depending on what was going on in their life. So that kind of contact with other drug users really did kind of increase the risk of polydrug use. And Ryan's just talking about how one of the bad times, he didn't really use a lot of stuff on top of heroin, but when his times were bad, he's just explaining there about how he used it to self-medicate for his pain and trauma that he was going through. Okay, so retaining or staying in treatment was really facilitated by the staff and the staff's approach to the treatment there. So they get supervised injection, which for some people that was a bit off-putting at the start, it's very personal. They self-inject with the nurses there watching. But as Terry says, they're really nice, they give you space, they watch over you, but they don't crowd you. And they really go above and beyond. Like Ryan says, they were in touch with him, especially at the start of treatment, ringing the hostel he was living in, getting him involved, encouraging him to go to the wraparound support, and slowly kind of developed really quite close supportive relationships with the staff because they're there so much, they see them like every day. The staff were like, I see these people more than I see my own family. So, and that really what helped participants through those ups and downs and overcome those barriers in terms of how much they could actually do with their days. Okay, and in terms of healing and recovery, so qualitative data supported all the quantitative data that's already out there. Stop shoplifting, haven't been to jail. This one particularly, Jessie, I had abscesses all over. I'm getting my legs sorted, so I'm getting proper medical treatment. And that's a really key thing because that HAT was embedded in an existing service. They had increased access to healthcare, so they were there every day. So abscesses that they might have had for years and years and years that were causing sepsis in and out of hospital, they actually finally got that stuff sorted. And like gynecological health and like just all everything was in there for them. It was a GP service and it had mental health and social support as well. So they accessed a lot of stuff through that. So social engagement and relationships, I think this is the thing that probably came out strongest from when the participants talk about what they got from it. And with my family now, says Brian, that's the best thing about this programme. I'm with my family because they actually finally were stable enough to start redeveloping those connections that had been damaged from, I mean, these people have been using heroin for 20, 30 years, you know, like really, really, I'm talking long-term use. But they did actually manage through the programme to start making those connections again, rebuilding connections with family and children as well, which kind of starts to address that intergenerational impact. Right, nearly finished. So, last one, emotional and psychological well-being. And really what gave them was a lot of chance for success in treatment when they've never experienced that before. So, because they've failed in treatment so many times before, but HAT, you know, just turning up was a success. Turning up twice a day for a week was a massive success. And through that, they really started to build their own self-confidence and their own self-worth and their own, you know, feeling that I can do it. And then slowly, you know, they start getting stable housing. And these things really kind of built on each other. And through that, the person kind of started to reconnect with themselves, their authentic selves. I feel like I found myself again. Coming here gives me a chance to turn over a new leaf. I'm starting to pick up the pieces and put it back together. So, as a quick conclusion, data-supported, existing evidence basis for HAT, motivation for change and staff support, facilitated engagement and retention, and healing and recovery happened across a spectrum of physical, behavioural and psychosocial outcomes. Okay, it was a little bit long, but not